Good morning. My name is Tammy Kozel. As mentioned, I am a pre-transplant RN care coordinator at Mayo Clinic, Rochester, and I'm pleased to be able to share a bit of information and present at this webinar this morning regarding the kidney transplant evaluation process. Much of my information will overlap with Dr. Isa's. So my objectives are to discuss who is a candidate for kidney transplant, to discuss the referral process, to discuss the transplant evaluation process, and to provide an overview of kidney transplant at Mayo Clinic, Rochester. So to begin, and just to make candidates aware, Mayo is a 3-site enterprise. We do have Mayo Clinics in Rochester, Minnesota, Scottsdale, Arizona, and Jacksonville, Florida. We do kidney transplants at all 3 locations. The information that I'm going to present today is specific to our Rochester location, but we can, and I am going to provide you with contact phone numbers for our Rochester location. But if you are interested in the Arizona or Florida locations, we can give you the contact information for those programs as well. But I did want people to be aware that we do have those 3 options, and whatever program works best for you depending on where you live. So in Rochester, we do have 4 pre-transplant RN care coordinators who work with the adult population, and then we do have 1 pediatric RN care coordinator as well. So to start, why would someone consider having a kidney transplant? Renal transplant is the standard of care for end-stage renal disease. Mortality rates on dialysis are nearly 25%. Our 1-year patient survival rate is 99.7%, which is excellent. The goal of a kidney transplant is to improve a person's quality of life and return them or to keep them in the workforce. We do recommend early referral to a transplant center if possible prior to beginning dialysis. Kidney transplant is a treatment option for some people. It is not a cure for renal failure. There are no guarantees, of course, with a kidney transplant. The organ may never work from the beginning. There can be complications, including infection or rejection, that may cause loss of the kidney function or loss of the transplant altogether. For some people, there can be kidney disease that recurs in the transplanted organ. With polycystic kidney disease, that is not a kidney disease that recurs with the transplanted kidney, fortunately. But for the great majority, there are big benefits from a successful kidney transplant. As Dr. Isa mentioned, freedom from dialysis, an increased sense of well-being, fewer restrictions on diet and activities, increased energy level, and being able to live longer with better health. So when is a person eligible for transplant, or when should they come forward to be evaluated? It is best if we can evaluate you as soon as your kidney function or estimated GFR, glomerular filtration rate, is at 20 or below. Certainly if a candidate is already on dialysis, they're eligible to be evaluated, but we'd like to get to you before that. If your GFR is in the mid to upper 20s, you may be a little too early to be evaluated because we can't really make you active on the waiting list, but we can consider bringing you, but you may be deferred and have to come back for another evaluation before we can make you active on the waiting list. Your body mass index needs to be less than or equal to 40. Body mass index is a measure of body fat based on weight in relation to your height. So there is a BMI or weight criteria. You also need psychosocial clearance and financial clearance. and I believe Erin Hamilton, who's our social worker and up next to talk, will probably be talking a little bit about those things. So how would a candidate go about being referred to Mayo Clinic Rochester? This is our toll-free number to contact if a candidate wishes to be referred. We would ask to get some demographic information, name, birth date, social security number, address, contact phone number, etc. And then we would ask that you fax your last year's medical records to us for review to the fax number that's provided there. So who can refer a candidate? Your local physician or provider, certainly your dialysis unit, or you yourself, the candidate, can refer yourselves as long as you know what the eligibility requirements are. Obviously, if a candidate doesn't know what their kidney function, if your kidney function is at 40, you're not ready to be referred yet for a transplant. So the candidate will then be contacted to do a brief phone screen with the RN care coordinator. We will not want every detail of your medical history, but we will want to know enough about you so that we know what your primary medical issues are, and we can order the appropriate testing for your kidney transplant evaluation. We will then transfer you to the appointment coordinator to arrange dates for the evaluation, and once we have insurance approval, we'll go ahead and proceed with scheduling. When we do the phone screen with the candidates, there are some absolute contraindications, again, as Dr. Issa mentioned, for which we may not proceed with offering an evaluation. Those would include things like inability to comply with transplant-related management and medical follow-up, an active malignancy or cancer, an active infectious disease, severe immune deficiency state, technical inability to perform the transplant surgery. That would be something like an occluded iliac artery where we would not be able to hook up or transplant a new kidney, and it wouldn't be able to get good blood flow. A patient that's unable to safely undergo anesthesia, or someone that has a life expectancy of less than 5 years. There may also be some other relative exclusion criteria. These would not be absolute exclusion criteria, but things like multivessel coronary artery disease with an ejection fraction of less than 35, severe chronic obstructive pulmonary disease, severe peripheral vascular disease, and poor functional capacity. If we feel that it's not in your best interest to proceed or that we cannot help to improve your quality of life, then we may not proceed with scheduling an evaluation. We may have to discuss with the team whether we feel it's in your best interest to come for an evaluation. For candidates who are over the age of 70 but are in good health, we will likely require that you have a living donor. It is in your best interest. It's not in your best interest to wait on a deceased donor waiting list for an average of 3 to 6 years. So we would want you to have a living donor. That's probably the best option if you're going to come for an evaluation and be approved for a transplant. Some basic principles to know about Mayo and our model of care as candidates come for evaluation. Mayo is recognized for having teams of specialists who work together. The transplant team is a multidisciplinary team with including nephrologists, transplant surgeons, RN care coordinators, social workers, dietitians, pharmacists, transplant financial representatives, endocrinology, cardiology, psychiatry, nurse practitioners, physician assistants, and many more. We partner and work together in collaboration with you, the candidate, as well as your local providers. The kidney transplant evaluation is done as an outpatient, usually over 3 to 4 days, depending on whether you are on dialysis and what other specialties you need to see. Dr. Issa has already kind of outlined what things we do when you come for the evaluation, but it includes blood work, chest x-ray, electrocardiogram, MRI of the head if it has not been done within the last 5 years, cardiac testing if it's appropriate, cancer screening tests such as mammogram, pap smear, colonoscopy, again, if age appropriate. We do have an education class, kind of gives an overview of the whole transplant process, and then meeting with all of the team members. If you're on dialysis, hemodialysis, we would also schedule that as well when you come for your evaluation. So during the evaluation, the candidate will receive education during their visits with all of the respective team members. However, there's also a separate education class for candidates which gives kind of an overview of the transplant process. We discuss anti-rejection medications and the potential side effects. We discuss the surgical procedure, their hospital course, and follow-up care. Once the candidate has completed all testing, consultations of the transplant evaluation, their case is then discussed in selection conference by the multidisciplinary transplant team, and then an outcome is determined. The candidate is then called and they are told whether or not they have been approved, deferred, or not approved. They will also receive a letter in the mail letting them know the outcome. So if you are approved, then we are going forward and we're ready to begin the donor process. So a donated kidney may come from either a living or a deceased donor. Getting a kidney from someone who is alive and volunteers to donate is the best option. Transplanted kidneys from living donors usually last longer and work better than those from deceased donors. A living donor could be a relative or a close friend, or possibly through our paired donor program. If approved, the transplant candidate will be made active on the UNOS deceased donor waiting list. With a deceased donor transplant, the recipient gets a kidney from someone who has recently died. The United Network of Organ Sharing, or UNOS, manages this national waiting list and is in charge of getting deceased donor kidneys to those who need them. The transplant candidate can be on multiple lists around the United States, and they may transfer their time from transplant center to transplant center if they wish. Unfortunately, with the UNOS list, the average waiting time for a deceased donor kidney is about 3 to 6 years. So these are just a few facts from the UNOS website regarding donation that may be of interest to you. As of about a month ago, there are over 118,000 people waiting for organ transplants. The median waiting time for a first-time kidney transplant is about 3.6 years. 3,000 people are added to the kidney waiting list each month. About every 10 minutes, someone is added to the list. Tragically, 22 people die each day waiting for a kidney. And just one donor, one deceased donor, can save 8 lives, the lives of 8 people. So turning our focus back to living donation, which is really the majority of the transplants that we do here at Mayo Rochester, there are many advantages or benefits to receiving a living donor kidney, which is the main reason that we really encourage folks to find a living donor if at all possible. These include living donation provides the best long-term outcome for the recipient. Living donation can often be done preemptively, which means you can get a kidney usually before you go on dialysis. Living donation or living donor transplants provide shorter waiting times. There is a lower rate of delayed graft function, meaning the kidney transplant usually works right away from the very beginning. There is improved long-term graft and patient survival. And the surgery is now donor-friendly with the hand-assisted laparoscopic donor nephrectomy, meaning there's less downtime for the donor. It's a 2-day hospitalization, smaller incisions, those kinds of things. So most living donors are a family member or a close friend. A living donor does not need to be related to you. They do not need to be the same sex or race. A donor needs to be at least 18 years of age to give consent. A donor cannot have diabetes or uncontrolled high blood pressure or have been pregnant within the last year. In most cases, your donor needs to be in overall excellent health, free of any infectious diseases, active cancers, or heart disease. Although there are some risks involved, living donors typically do not have long-term problems after they donate a kidney, and they can continue to lead a healthy life with their single remaining kidney. That's just kind of a brief overview. Lisa King is going to be giving a talk on living donors this afternoon, so I'm going to let her give more details. So there are several tests that we do to see whether a donated kidney may be a good match for the recipient. The first blood test that we do is the recipient's blood type. It's best to get a kidney from a donor that has a blood type that matches or is compatible with the recipient's, as seen in this slide. The blood RH factor, as Dr. Issa mentioned, negative or positive does not matter when it comes to a kidney transplant. In addition to the blood type test, there is a tissue typing test, which is where we check the recipient's antigens or genetic makeup and compare it with the donors. A kidney transplant can be successful even if your tissue types or your antigens do not match. Another test that we perform is a cross-match test. In the cross-match test, the part of the recipient's blood that carries antibodies is mixed with the donor's white blood cells. The results of the test are either positive or negative. A negative cross-match means the recipient's blood and the donor's antigens are a good fit. Again, it's best if we can get a negative cross-match, but in some cases, donors with a positive cross-match may work. So if a recipient has a living donor who wishes to donate, but they are blood incompatible, or they have antibodies against the donor, or they are not a good match for some other reason, then Mayo does offer our kidney paired donor program. Again, I'm not going to go into great detail about this. Dr. Esau has already talked about it, and I think Lisa King will give more details this afternoon about paired donation. So whether you have a living or a deceased donor, kidney transplant surgery is typically about 2 to 4 hours in length. Dr. Dean is going to go into more details about this also this afternoon. With people who have polycystic kidney disease, if they are symptomatic from their polycystic kidneys, they may have the option of having those polycystic kidneys, either one or both of them, removed at the time of transplant if it's necessary to do so. And Dr. Dean can speak more to that at that time. So once the surgery is over, the hospital stay after having a transplant surgery is approximately 3 to 4 days in length. During the time in the hospital, the transplant recipient begins taking anti-rejection medications, and they begin their post-transplant education. Upon dismissal from the hospital, recipients are expected to stay in Rochester for a 3 to 4 week outpatient stay and are required to have a caregiver with them. The 3 to 4 weeks in Rochester is vital for close follow-up, and during this time, the patient's responsibilities are to take their anti-rejection or immunosuppressive medications every day, communicate any health changes or illnesses to the transplant team, learn their medications, obtain their routine blood work every 1 to 2 days, and attend outpatient appointments for medication adjustments and medical assessment, and record their blood pressure, temperature, weight, and lab readings in their record book. The responsibilities of the transplant team are to monitor for infections, monitor immunosuppression, drug levels, and adjust medications based on lab values, assess health status changes, seek additional referrals based on the patient's needs, and continue patient education and answer questions. Post-transplant, all that the team does is to prepare to dismiss the post-transplant patient home. Having the necessary education is critical to ensuring the best possible outcome after having the transplant and helping the patient to assimilate the kidney transplant into their lifestyle. Having a kidney transplant can bring many changes to the recipient's life. So we want them to be absolutely certain that they are best equipped to manage those changes upon returning home. We also want the transplant recipient to have a well-established partnership with their Mayo Kidney Transplant team and their local physician or provider, so we can all work in collaboration toward mutual goals of long-term, successful transplant and healthy lifestyle for the recipient. Of course, we cannot emphasize enough for the recipient that the best outcome for their transplant is, for the best outcome of their transplant, it will be vital for them to take their anti-rejection medications every day as prescribed, have routine blood work as directed, and return for follow-up appointments on a regular basis. With regard to long-term follow-up once leaving Rochester, the first return follow-up appointment is a 4-month checkup, then at 1 year. Return visits will focus on cardiovascular health and maintaining good blood pressure control, management of lipids, diet and exercise, and glucose or blood sugar control. Recipients need to continue to comply with taking their medications, getting blood draws at regular intervals, and coming to appointments when instructed. Protocol kidney transplant biopsies are performed at 4-month visits, 1 year, 2, 4, 7, and 10-year visits. These biopsies give the transplant team vital information demonstrating early changes in the kidney transplant that can clue us in and allow us to make adjustments in the recipient's medical management. Long-term follow-up is key. Often failure to comply with medications, blood draws, or follow-up appointments may lead to a shortened lifespan of the kidney. So in summary or conclusion, the kidney transplant is a treatment option for end-stage renal disease. Again, it's not a cure, but if someone undergoes a kidney transplant, it will mean a lifetime of medical management, including taking anti-rejection or immunosuppressive medications every day for the rest of your life, getting blood work regularly, and returning to see the transplant team at intervals. But a successful kidney transplant truly is a wonderful gift that can improve quality of life, especially when you have a team approach that includes you, your family, your local doctor, and your transplant team. Thank you much for your attention. I will just put up our Transplant Center phone number if you wish to consider being referred for an evaluation. Yeah, we can save questions and discussions after Erin's presentation.
So now we're going to consider more of the transplant evaluation and financial consequences or things to consider. And Erin Hamilton is now, she's a social worker in the Transplant Center here at Mayo.
Thank you. My name is Erin Hamilton, and I'm a clinical social worker here at Mayo Clinic's Transplant Center in Rochester, Minnesota. I serve on the multidisciplinary team of providers who work with all transplant patients. And my primary population are patients needing or who have received a kidney transplant and or pancreas transplant. So a few things that I want to go over with you today. I want to discuss the role of the transplant social worker, talk about a patient support system and caregiving plan, and also try to address some common financial concerns and questions related to kidney transplant. So what is a transplant social worker? All transplant centers have to have a master's level social worker on their team to meet with patients. And we work with patients from the beginning to the end. We meet with them during the initial evaluation. We'll continue to meet with them up until transplant. We meet with them at least once when they're in the hospital and then after transplant. And we're available to them lifelong for issues that may come up. Some of the things that we do, we complete an initial psychosocial assessment, and I'll go into a little bit more detail about that in a minute. We assist patients with addressing barriers to transplant or just issues that they're facing in their lives. We provide recommendations to patients and to the medical team. We connect patients and their families to various community resources. We provide ongoing education and also supportive counseling to patients and families. So like I said, we meet initially with patients and their families to do what we call a psychosocial assessment. So we're looking at the psychiatric, psychological, social aspects of a patient's life. And there are different components of this assessment. We'll take a family history with the patient. We'll look at their current lifestyle and learn how they're adjusting to their illness and to the idea of needing a transplant. Going along with this, we'll look at their coping strategies. So considering both their unhealthy or their less desirable coping strategies, as well as their positive or healthy coping strategies. We work with the patient to learn their understanding of the medical illness and of transplant in general. We talk a lot to patients about medication compliance, and as you've learned, this is a big one. Patients will be on immunosuppression medications the rest of their lives after transplant, and it's very important to take those exactly as they're prescribed. So we want to make sure that patients have developed the habits of taking medications and following a more complex medical regimen. We'll talk to patients about their support system. We'll look at a patient's mental health, both currently and their history of mental health. Also their substance use, so what their patterns of tobacco use, alcohol use, illicit drug use is currently and then as well in the past. And then we also work with patients to identify their financial resources and any financial stressors that they may have. And I'm going to back up one more time. With this information that we gather from the psychosocial assessment, we use it to help determine if a patient is ready for transplant. We also use it to identify any areas of concern or areas in their life in which that they can improve. Support and caregiving. I wanted to talk a lot about this, or a little bit about this, because it is a very important part to a successful transplant. Transplant is a major life stressor, and with all life stressors, you need help, you need support from family, friends, community. So a good support system, a healthy, positive support system is imperative to the success of kidney transplant. And your support system can include your immediate family, your extended family, friends, neighbors, community. It's really those people and those groups that you can tap into to gain support and assistance and guidance. And most transplant centers require a patient to have a caregiver, ideally throughout the entire process, but certainly at the time of transplant in the hospital and after transplantation as well. So what is a caregiver? A caregiver is a person or persons who can provide support and assistance to patients throughout all phases, in our case, of the transplant process. And the duties of a caregiver, I've listed some. It's certainly not an exhaustive list, but they accompany patients to transplant-related appointments, provide assistance with transportation, for instance, provide emotional support, serve as a liaison between the patient and their family, and also as a liaison between the medical team and the family, and then assist with kind of daily activities, household activities, including grocery shopping, cleaning, laundry, etc. The role of a caregiver, as I said, is extremely important. It can be a very stressful role, and we actually have a term for it. It's called caregiver burnout. Some common signs of stress seen in caregivers are feelings of anger, frustration, anxiety, sometimes resentment toward their loved ones or towards the patient. You can have physical symptoms, headaches, backache, cold, fatigue, insomnia. Increased substance use. This is particularly seen in people who may have a substance use history. Loss of interest in activities once enjoyed, and lack of attention to your own needs. So some tips for caregivers to manage their stress or to manage this role. We want you to be very cognizant and aware of how you're feeling. So monitor and address that stress. And then maintain self-care, whether it's relaxation techniques like breathing exercises, eating healthy, sleeping well, accepting assistance from other family and friends, or delegating tasks to other family and friends, exercising, seeking supportive counseling, and taking regular breaks. There are a variety of resources available to caregivers, of course, transplant social workers, and I probably would extend this to your entire transplant team. If as a caregiver you're feeling stressed or fatigued, overwhelmed, I would encourage you to talk to anyone on the transplant team about that. There are local support groups in most areas. I know we here at Mayo Clinic have 2 ongoing support groups that caregivers can attend, and most other transplant centers have something similar. There are online support groups for caregivers. Other caregivers are a great resource to you. You'll oftentimes meet them out, in the lobby of your medical appointments, or if you're staying at the local transplant house, you'll run into them, and they're great to talk to because they can relate. They know what you're going through. They're going through something similar. And then, of course, your friends and family. Okay, switching gears a little bit, and I know I'm running through these quite quickly, but I want to make sure we have time for questions at the end. I don't have hard statistics, but anecdotally, I would say most of our follow-up phone calls, questions, kind of crisis type of situations have to do with financial stressors, and understandably and rightfully so. Kidney transplantation is expensive. The average cost of kidney transplantation is about $262,900, and that's mostly the medical costs involved. It's important to know that there are medical costs and non-medical costs related to kidney transplantation. So those medical costs include your insurance deductibles and copays, the cost of your medications, your transplant evaluation, the actual surgery, of course, and follow-up appointments after transplant. And some of the non-medical costs include, or could include, time that you have to take off of work, and if you're not paid for that time, so lost wages. And then the cost of traveling to your transplant center, so the travel, meals, and lodging related to those trips. Who can help address some of these financial concerns? So as I said in the beginning, all transplant centers have to have a social worker on their team, but many transplant centers also have what's called a transplant financial coordinator. We call them transplant financial services here at Mayo Clinic. Some of the things that they can do are review current insurance coverage and help determine if a patient needs additional coverage, confirm any authorizations needed for transplant, assist with ESRD or end-stage renal disease Medicare applications, assess financial barriers to transplant, and connect patients to available financial resources, whether it's resources through their community or through drug manufacturers. We can help patients seek those out. So related to finances, it's important to be prepared. It can help, I wouldn't say eliminate any financial stressors, but mitigate or decrease some of the anxiety that you might have regarding finances and transplant. To begin with, talk to your insurance provider. Learn how they cover the cost of the transplant. Will you have out-of-pocket costs? If you want a second opinion at another transplant center, will this be covered? Discuss any leave policies with your employer, and this is important for both the patient and the caregiver as well. Research financial assistance programs. So again, many drug manufacturers will have patient assistance programs to cover the cost of their medications. There are some state grants specific to transplant patients, and your transplant social worker can help you locate a lot of those programs. Consider fundraising efforts. I always encourage most of my patients to think about fundraising, and I think a lot of people are a little reluctant or hesitant to do so for a variety of reasons. But I always tell people it's a nice way, it's an easy way for many people in your life to help you out. When you're sick, a lot of friends and family want to provide you with assistance, and they can't. Not everyone is going to be able to give you a kidney. But if they can donate financially, it makes them feel like they're helping out, and they are helping out. And then lastly, and most importantly, maintain insurance. This is huge. If you take nothing away but this, today I would be okay with that. Maintain, of course, insurance up until transplant and then after transplant. Those immunosuppression medications are very expensive, and we want to make sure that you can afford them. If you can't afford them, you're not taking them. If you're not taking them, you can lose the transplant. So again, medications, lifelong immunosuppression medications, they are quite expensive. I'm not going to go through this entire list, but talk to your insurance provider, find out how your immunos will be covered, look for prescription drug programs, and then work with your center's social worker to apply the patient assistant programs for that particular medication. So persons who have received a kidney transplant are a unique population in that once you receive a kidney transplant, you become eligible for Medicare, and it's called ESRD Medicare, or end-stage renal disease Medicare. The criteria that needs to be met in order to be eligible for ESRD Medicare is that you have to have that diagnosis of ESRD, and then require either chronic dialysis or receive a kidney transplant. And then it's also important to know that in order for any of us to reap the benefits of Medicare, we have to pay into it over our working lifetime. I can't remember exactly how many years it is. If you're a spouse who is not working, you can qualify under your spouse's kind of working credits is what it's called. There are several parts to Medicare. The two parts that I usually go over with patients are Part A and Part B. Part A covers the inpatient hospitalization, and there's no premium involved, so there's no cost to you. Part B covers outpatient medical expenses, about 80% of those medical expenses, and there is a monthly premium which is based on a patient's income level. The important thing to remember about Part B is that when you sign up for Medicare, for ESRD Medicare, at the time in which you're eligible, your immunosuppression medications will be covered under Part B as in boy. When does ESRD Medicare start? For kidney transplant recipients, it begins the first of the month of kidney transplant. So if you had a kidney transplant on March 25th, 2017, your coverage would start March 1st of 2017. When does Medicare or ESRD Medicare end? After a kidney transplant, it ends 36 months after. So again, using that example, if you start March 1st, 2017, it'll last through the end of February 2020. It's important to note that this applies to people who are on ESRD Medicare only and not also eligible through Social Security disability or who have aged into it at the age of 65. How does one enroll in ESRD Medicare? You can enroll, the Social Security Administration are the ones who process the applications. So you can go to your local Social Security Administration. I've put a link on there for there's a search tool on their website where you put in your zip code and can find where your local office is, and then that's the phone number for Social Security. Many transplant centers, ours included, or dialysis units work with patients to complete the necessary application, and there's actually a form that has to be completed and signed by your providers at the transplant center or your dialysis unit. Again, a few helpful resources, mostly related to the ESRD Medicare. Medicare has a booklet that they go into a lot more detail than I did regarding ESRD Medicare. Every state has what's called State Health Insurance Assistance Programs, or SHIP, where they will work with patients to navigate the Medicare system, to navigate supplement plans, etc. And then, of course, Social Security Administration, SSA.gov. So again, I know I breezed through that, but I wanted to leave enough room for questions. So if anyone has questions, comments, concerns for me or Tammy, now's your time.
Thank you so much. That was great information, and we do have lots of questions, so we'll get to as many of them as we can. Can you tell us about how long the evaluation process is for the recipient? How long it takes?
The average recipient evaluation is about 3 days. It will depend on whether or not you are on dialysis. Dialysis will take 3 to 4 hour chunks of time out of the day. So that's going to add a day or two to the evaluation. If you have cardiac problems, you're going to have to see a cardiologist when you come. If you've got other health issues and you need to see other medical specialties, it's going to add. If you're a very straightforward patient, I would say 2 to 3 days is probably what you could expect.
Okay, thank you. We had several questions about age for the transplant recipient. So what is too young, what is too old to receive a transplant or to be evaluated for a transplant?
We're bringing up yet another speaker. We're bringing up Dr. Issa.
Okay.
Yeah, that's actually very variable across different centers. In our center, we don't really, there is no cutoff for age, tell you the truth. Typically for patients older than 70 years, we have a preference for living kidney donor transplant because simply, an older person cannot wait, up to 5 or 6 years to get the transplant. We had instances in the past, we transplanted people in their 80s. They have a living donor. We shy off of that now, but there's no real cutoff. It depends on center. It's very individualized. We have people in their 70s who are healthier than people in their 20s. So it depends on the person and the patient.
Okay, thank you. Is there a cost for listing at more than one center?
There is no cost incurred by the patient himself. It's a cost to the transplant center. Each time we list a patient, yes, there is actually a nominal cost that we pay as a center. I think it's $800 or $900, but the patient does not actually incur that expense. It's the insurance or Medicare, whoever, but it's the center who pays it. Patient himself or herself does not pay anything.
Okay. And can you tell us at what age would a child of a PKD patient be able to be cleared to be a donor?
Yeah, that's a good question, and you have people who are experts in PKD. You know, we do actually screening. Nowadays, there is genetic testing that can be decisive in terms of PKD. We prefer, you know, donors to be older than 30. We screen any potential living donor has family history of PKD. You know, it's autosomal dominant inheritance. So a child of someone who has PKD can be affected 50%. If they're older than 40 and they don't have any cyst on basic screening like an ultrasound, I think they can donate. Now, between the age of 30 and 40, it depends. There are criteria actually on the number of cysts in each kidney. If they're really younger and we need to cut to the chase, we do a genetic testing that's available. It costs a few $100, I think around between $350 to $400 to do it. Sometimes it may not be actually covered by insurance. So sometimes the transplant center can actually get the cost and pay for it. So if the donor is older than 40 with family history of PKD, first degree parents, meaning they're older than 40, no cyst, it's safe to donate. Between 30 to 40, depending, you know. There are certain criteria that we go by, and depending on the number of cysts in each kidney. But the best screening, I would say, if we know the mutation, is doing the genetic testing.
Okay.
Question?
Yeah, I have several more actually.
Sure.
How difficult is it for people of color or people that may not have insurance or financial resources to get a transplant?
Okay, maybe I'll turn that to Erin. So, what resources do we have for people who don't have insurance?
So, and I can really only speak on behalf of how we, we do things at our center. I can't speak how other people do. I know if patients are underinsured or uninsured, oftentimes we may not even bring them for evaluation until they get adequate coverage. If they're not if they've gone through evaluation not adequately covered, we may put them, their status on hold until they are able to get adequate coverage. And then from there, our transplant financial resources, and sometimes us in social work, can link them to the various programs, whether if they're on Social Security disability, seeing how much longer they need until they qualify for Medicare, linking them to their state medical assistance programs or Medicaid, linking them to marketplace plans, seeing if, are they employed? Does their employer offer insurance? Does their spouse have insurance that for whatever reason they're not on and they can become on? If, for instance, you have an insurance that we don't contract with, we'll help you, or we can help you maybe find other transplant centers that contract with your insurance. As I said before, it is an expensive process, and we don't want to set people up for financial failure and financial stressors in the end. So we want to do as much upfront work as possible to make sure that they're not, facing those conundrums after transplant. I don't know if that answers your question or not.
I think so. Thank you. So we've had a couple of questions about substance abuse concerns about what that is and what things would be considered substance abuse. Specifically, is smoking marijuana okay since it's legal in some states?
Right. Well, that's a debatable question, but you know, active substance abuse such as cocaine is actually an absolute contraindication, or any intravenous drug use. Those are actually absolute contraindication. We don't take patients who are actively doing drugs, especially, you know, the heavy ones. Now, for marijuana, depending on, you know, the evaluation by our transplant social worker, most of the time we actually have help from addiction psychiatry here. But we have instances where we took actually patients with active marijuana use. There are people who use it for to enhance their appetite or for medical use. Those we don't discriminate against. But it's not their major contraindication. However, we actually really caution people post-transplant about the use of marijuana, because smoking marijuana, especially it can have some impurities, and we have instances where patients actually get bad fungal infections in the lung from the use after transplant. It's well known some impurities in smoking. I mean, in the herb itself, actually, something called aspergillosis is very frequent to be found. So we prefer people who don't smoke it, but it's not actually a major contraindication for marijuana itself. But the other substance use, we actually don't offer transplant unless we enroll patients in certain programs and they prove that they're abstinent. You know, alcohol is same as well. We enroll patients in certain programs, and we have help with addiction psychiatry here. But marijuana is actually not, it's a gray area, but we don't discriminate much, I would say.
Okay, thank you for that. I have a question about insurance. Can prior authorization be done through insurance for an out-of-network hospital for a transplant, and when should this request be made?
Okay, I'll turn you to Erin. Do you know that?
I don't know if I don't know the actual answer to that, because we here at Mayo Clinic have Transplant Financial Services, and they do a great job in working on that. So I think your first question was, can a pre-auth be made for out-of-network centers? I think the short answer is yes. And at what point? I think ideally before the patient comes for the evaluation, because you want to make sure that that evaluation will be covered under your insurance. And who will do that? Again, we have the Transplant Financial Services. Other centers have something similar. If they don't, then probably their business office.
No, we have limited experience, I mean, on the financial aspect, but some patients can petition actually their insurance company to get them prior auth to go to another transplant center if there's certain expertise. For example, here at Mayo, we have expertise in polycystic kidney disease patients, how to manage them, manage the large kidneys. We have expertise in certain glomerular diseases that can recur after transplant. So at times, some patients actually, if they're listed in a center that actually, I would say low volume center that does not have the expertise, they have high risk of recurrent kidney disease, certain diseases like FSGS and such, they can actually petition their insurance. Their doctor can help them to write a letter to get actually exception to be covered in a center that has more expertise in certain diseases. PKD is one of the actually those expertise that we have actually accrued over time. Especially our surgeons are very well equipped in helping people throughout, you know, taking the native kidneys out at the time of transplant. Other centers don't do that. So yeah, patients should advocate for themselves with the help of their physicians. They can get some exceptions.
Thank you for that. So we'll ask one more question and then it'll be time for our break. So we understand that Medicare stops paying for immunosuppressive drugs after 3 years. What are the options for patients at this point?
After that 3 years is over?
Yes.
So essentially, you know, the idea, I think, the rhyme or reason for Medicare ending 3 years after transplant is, the idea is that once you receive your transplant, you're going to be well enough to go back to your quote-unquote normal life, work, you know, be in the workforce, and then hopefully get employer-based insurance. So that would be the easiest way, is insurance through your employer. If you're not working, or if your employer does not offer insurance, if it's a smaller company, for instance, right now the option would be to go through either your state marketplace plan or the Affordable Care Act plans. You can go to healthcare.gov for that. And then if you're within certain income levels, and that's based on county by county across the country, if you fall within certain income levels, you may qualify for medical assistance or Medicaid through your state.
Okay, thank you very much.